Imagine a battlefield within your own body. Every month, without warning, pain blooms where there should be peace. This is the story of adenomyosis, a hidden condition that affects up to 1 in 3 women, yet often goes undiagnosed for years. Adenomyosis is a condition where endometrial tissue, which normally lines the inside of the uterus, starts growing within the muscular wall of the uterus, the myometrium. This misplaced tissue behaves like regular endometrium. It thickens, breaks down, and bleeds with each cycle, but the blood has nowhere to go. The result? Chronic pain, heavy periods, bloating, and inflammation. Estrogen, the hormone of growth, becomes a key player in adenomyosis. Women with this condition often show increased estrogen receptor activity in the uterus, making them hypersensitive. An enzyme called 5-alpha reductase also converts testosterone into dihydrotestosterone, which mimics estrogen and furthers tissue growth. Worse, many women experience impaired estrogen metabolism. Elevated levels of estrone compared to estradiol create a hormonal imbalance that invites tissue invasion. While estrogen pushes the gas pedal, progesterone should hit the brakes. But in adenomyosis, there is resistance. The receptors fade. The message is lost. Progesterone can no longer slow down the cycle of proliferation. Inflammation adds fuel to the fire. Cytokines like TNF-alpha and IL-6 create a hostile environment. Angiogenesis, the formation of new blood vessels, allows endometrial tissue to expand deeper. Some women may also carry a genetic predisposition. Mutations in KRAS or PK3CA, genes involved in cell proliferation, increase the risk, and epigenetic changes can switch genes on or off, further promoting invasion. Adenomyosis is most common in women between 40 and 50, but increasing diagnoses in younger women suggest it's more widespread. Many remain undiagnosed for years, often dismissed as having bad periods. For many, the impact goes deeper. Adenomyosis is increasingly associated with infertility. When combined with endometriosis, the prognosis worsens. One study found a 68% lower chance of pregnancy after surgery for endometriosis if adenomyosis is also present. Diagnosis once required a hysterectomy. Today, advanced imaging is changing the game. Transvaginal ultrasound offers a cost-effective first look, while MRI provides clarity, particularly for the junctional zone. If the EMJ exceeds 12 mm, suspicion of adenomyosis rises. Adenomyosis is also linked to higher rates of miscarriage, preterm labor, and preeclampsia. The altered uterine environment can interfere with placental attachment and uterine contractility. Treatment is not one-size-fits-all. It depends on symptoms, fertility goals, and severity. NSAIDs for pain relief. Hormonal IUDs like LNG-IUS reduce bleeding and pain. Oral contraceptives regulate cycles. Dienogest, a progestin, suppresses tissue growth. GnRH analogs suppress hormone production but require monitoring. Aromatase inhibitors reduce estrogen synthesis. SPRMs like ulipristal acetate offer symptom relief. Adenomyomectomy preserves fertility by removing lesions. Uterine artery embolization reduces blood supply. Radiofrequency ablation targets tissue via heat. High-intensity focused ultrasound destroys tissue non-invasively. Hysterectomy remains the definitive solution when all else fails. With new imaging technologies, AI diagnostics, and less invasive interventions, the future looks brighter for women with adenomyosis. Precision medicine is paving the way for earlier detection and better outcomes. Adenomyosis is real. It's painful, but it's manageable. With awareness, diagnosis, and care, women can reclaim their bodies and their lives.